All right, it's all yours.
Okay. Thank you for that introduction, and thanks everyone for having me join you today. By way of introduction, I am about 4 years into practice as an emergency physician. I did my training in Edmonton and then moved to Queen's University, which is where I currently practice. I have a blended practice which is very heavily clinically oriented, and I also do some teaching and research. Some of the teaching that I do is on health advocacy. And we've recently developed a curriculum around health advocacy. And this is a little slice of something that I've been giving to the residents, adapted to your context. I understand many of you are working in rural and remote settings that you're making some very valiant efforts to do everything you can to treat the patients in front of you, and there are times when it's really hard. So this lecture and this workshop, really, it's meant to be as interactive as you can be, is meant to try to unpack some of those things. Some of these things that I talk about may be difficult to some and may resonate. If it doesn't resonate, that's okay. Just tune in and sit along for the ride. If it resonates, that's great, and I can hang around for a couple of minutes afterwards to explore some thoughts and ideas that have come up. If you have comments, if you want to, if you feel comfortable participating, please feel free to speak. Feel free to enter it in the chat. I think that's going to be helpful to get the discussion going. It's meant to be very interactive, although I appreciate that the format of Zoom is a bit challenging for this. Okay. So before we get started, I just want to acknowledge that I'm actually joining you from Queen's University here in Kingston, and that we're situated on traditional Anishinaabe and Haudenosaunee territory, and that we are grateful to be able to live, learn, and play on these lands. Today, we're going to talk about a few things. One of them is going to be to understand the different types of implicit bias, um, and how it might impact your perception of other people, where your own personal biases may come from, and then appreciate how that impacts your clinical practice, and how you can prevent it from doing that, with the overall goal of promoting equity in patient care. Okay, so let's start off with some terms. So explicit bias refers to attitudes and assumptions that we can acknowledge as part of our personal belief systems. Like some people, they prefer ketchup on their mac and cheese, and other people do not. That is an explicit bias. Some people just love ketchup on everything. They have a bias towards ketchup. And some people hate ketchup. They have a bias against ketchup. And similarly, that can be part of any other systems of a belief that we have. This can be self-reported and it can be measured. This differs from implicit bias, which was previously termed unconscious bias. And here, this is something that's more challenging to get at because it's people have a harder time really understanding that they have this. So people aren't aware of it, and so it's harder to measure, because it's a process that can happen without people really knowing it's happening. Specifically, these are attitudes and beliefs about race, ethnicity, age, ability, gender, or other characteristics that operate outside of our unconscious awareness. Implicit biases surreptitiously influence judgment and can, without intent, contribute to discriminatory behavior. So I'm going to share a different screen here. Bear with me. I hope I do it right. There's a video that I am hoping will work for you. And this just is an introduction to implicit bias here. Let me know if you can't hear the audio.
Implicit bias.
Implicit bias.
Implicit bias.
2016 was the year that implicit bias went somewhat mainstream.
Yeah, so when Hillary Clinton mentioned implicit bias in the debates, our phones started blowing up, all our friends started emailing us about it.
But what is implicit bias? Implicit biases are basically thought processes that happen without you even knowing it. Little mental shortcuts that hold judgments you might not agree with. And sometimes those shortcuts are based on race. First, some clarity. Saying someone has an implicit bias is different from calling someone a racist.
The word racist is a highly loaded term, right, here in American society. A lot of times, when people are using it, they're thinking of the kind of old-fashioned Ku Klux Klan style racist.
But implicit bias isn't anywhere near that, explicit.
Implicit bias is something that comes out of ordinary mental functioning, out of how the mind normally works.
We've all grown up in a culture with media images, news images, conversations we heard at home, our education. Think of that as a fog we've been breathing our whole life. We'd never even realized it, what we were taking in.
And that fog causes associations that lead to biases.
I somehow know that if you say peanut butter, I'm going to say jelly. That's an association that's been ingrained in me because throughout my life, peanut butter and jelly are together. And in many forms of media, there's an over-representation of Black men and violent crime being paired together.
And because of that, I actually deep down inside have been taught that Black men are violent and aggressive and not to be trusted, that they're criminals, that they're thugs.
With all those associations, I'm not trying to let us off the hook, but in some ways, none of us stood a chance.
Starting today, we'll post a video a day dealing with one challenge of understanding implicit bias and its relationship to race and exploring ways we might combat the problem. One more thing, if you're seeing this and thinking that it doesn't apply to you, well, you might be falling prey to the blind spot bias. That's a scientific name for a mental bias that allows you to see biases in others, but not in yourself. We're biased.
Hey, I hope that was informative. The New York Times has a series of free videos that you can go through on your own time to explore this a bit further. They're really well done and they're quite interesting if you have an interest in that. So as they were talking about, implicit bias is a way that you categorize the world. So you attach labels and meanings to things. And this stems from childhood. When you were a child, if you think back, like if you were maybe 5 years old, imagine as 5-year-old self, what age you categorized as old. Was it like 18? Maybe 30? I have to admit that as I've gotten older, what I perceive as old has also changed. So these perceptions can change over time based on personal experiences, but there are some things that you learned in childhood that actually don't change. And there's research that shows that some of these implicit biases, for example, pro-white bias, form at about age 3 to 5. And this is subconscious, and it dictates some of our personal and professional behavior and choices. Another example is maybe some of you were athletes growing up. Maybe some of you did sports. For example, I did synchronized swimming. There's part of me that says, yeah, I'm a synchronized swimmer. But the last time that I actually did synchronized swimming was over a decade ago. But it's my bias that I've developed. And I think, okay, well, this is how I see myself. This is how I see the world. And so you maintain these implicit biases over time. What are some factors that are influencing implicit bias for yourself? A lot of them come down to things like lived experience, things of socialization processes. So how were you introduced to society by your family or your caregivers? And then what are some of these personal and professional norms? And perhaps those themselves are biased. So to try to understand implicit bias, Harvard has developed an implicit association test. And I'll put this up here. This is what the link looks like. And some of you may be interested in checking this out. There's a QR code as well as a web address on the slide here. And there are many different types of implicit bias. And these implicit association tests are trying to get at these underlying associations, and they have you basically associate things in different ways as fast as you can. to try to overcome your higher level thought processes. They take about 10 minutes. They're free. You don't need to share them with anyone. It's just some nice food for thought to reflect on, okay, where do you sit on a topic? I won't get too heavily into this. There's a lot of evidence that supports it. There are some limitations of it. And the biggest one that I'll talk about really is that it changes based on your context. So perhaps if you're tired and grumpy after a shift, you may have different implicit bias towards a certain population than you might at the start of your shift. And an easy analogy is many of you may have children. You imagine you love your child, you know you're supposed to be patient with them, but you might be much less patient with them if you've been short shifted or you haven't slept, even though you know you're supposed to be patient with them. So the context does change the implicit association test a little bit. So take your results with a grain of salt, but it's a really nice way to explore what some of these underlying associations are in your own head. But what does it really mean? Because everybody has bias and it's part of human nature and it's part of what lets us survive from a day-to-day in the world day-to-day. We're going to talk about that a little bit later. Everybody, including hardworking and caring and empathetic people, have bias. So really, we're not saying that people are racist. We're just saying that everyone has this. And is there a way for us to game this so that we can be aware of this bias, that we have this bias, and then check it before it impacts our clinical work? I'm going to introduce 3 cases here, and we're going to come back to them at the end of the lecture. These are all true cases, and they're all patients that I've seen myself. So this is a gentleman, he's 43 years old. He comes into the emergency department, and you can imagine it at your nursing station. He is living with his mom at the age of 43, and he has a history of alcohol use disorder. Mom phoned an ambulance because he wouldn't stop drinking, and mom really wanted him to stop drinking alcohol. And his intake was about 6 to 10 beer every day, and he doesn't have a history of alcohol withdrawal seizures. So you talk with him, and he doesn't really have anything else significant, no other major concerns. He says, yeah, my mom's probably right. I should probably stop drinking, but I don't really want to go to detox. I'll do this at home. And you come up with a really good plan. You give him some Valium, you give him some information, some resources, and you send him home and you spend a bit of extra time with this guy because you're like, you know what, maybe I can actually change this person's trajectory and I can get them off of alcohol. And then you're working same place 3 days later, and the ambulance brings this gentleman in again. And his mom has phoned the ambulance again because he won't stop drinking. And you're like, okay, well, I already know this person. I'm going to sign up for them. I'm going to pause and ask you to just reflect on what you think you may already know about this patient. Do you know anything about his race, about his employment, about his cultural values? So this is what the patient looked like. Just reflect on if this is in keeping with what you were thinking or different. Do you have more context now that you see this picture? Did you make any assumptions that were maybe incorrect, maybe yet to be proven? Okay. The second case is a 62-year-old lady that was brought in by police. She called the police because she said there was a break-in at her apartment, and she lives in a low-income housing complex. So she said there was a break-in. She lives on the 5th floor. There was a break-in, but the police arrived and they said, well, there was no evidence of break-in. But there was broken glass everywhere. There was blood on the walls. It looked like there was quite a scene in her apartment, but the police said they didn't see anybody. They then go on to tell you that she does have a history of psychosis, and they found several cuts on her arm, and they think she's probably having a psychotic break. and that she was self-harming. Just think for a minute about what your approach would be to this patient. Some of you may have seen a similar patient before. How do you go about managing this patient? Interviewing her, caring for her. Okay, next case is a patient who's 21 years old, and he was brought in from prison. We have 3 prisons in our area in Kingston, so we actually do see a lot of the prison population in the emergency department. But you could imagine this at your nursing station as well. So this patient was placed in a room that was in a fast track area in our emergency department. And there are lots of other patients around this room. He had been assaulted and punched in the face, and you're worried about some eye trauma. His eye is swollen, and you worry that he may have a change in his visual acuity. So you want him brought out of that room and down the hallway where the visual acuity chart is, so that you can measure his visual acuity. And so you put in this order, and you ask the nurses, or as nursing colleagues, you're tasked to do this. And you also note that in this hallway, there is a mom and a small child who had fallen and scraped their chin and needs some stitches. And this person from prison would have to go past them to get to the visual acuity chart to be able to take his visual acuity. So this is what he looks like. Does that change your decision making? Does that change what you do? So I'm going to switch gears and talk a little bit about the historical context. Some of you may recognize these photographs. Potentially the one on the right is better known. The one on the right is Brian Sinclair. And this is a gentleman who died after waiting 34 hours in a Winnipeg emergency department. The staff thought he was intoxicated, but he actually died of urosepsis because he had a blocked Foley and could have been easily treated had his Foley been unblocked. The picture on the left is a picture of the syphilis, the Tuskegee syphilis trial, which they followed a group of people in a rural community in the United States, where there was a high prevalence of syphilis. And they were interested in studying what the long-term effects of syphilis were. They pretended to give medications, but were not giving the well-established and effective treatment of penicillin to these people, to this population, because they wanted to continue to observe the natural effects of syphilis. So I think the question of does systemic bias still exist, is perhaps a loaded question, and should rather say, how does systemic bias still exist? There are many different examples of this, but in settings, you could think about research, who's included in trials, who gets funding application, who sits on grant review panels. Are these people diverse? Do they represent different views? Not always. Another example is the use of titles. There are many female nurses here. I do wonder if any of you have been ever mistaken as a physician. Many of my male nursing counterparts get mistaken as physicians quite often. And as a female physician, most shifts I get mistaken as a nurse. Then we also want to think about the hidden curriculum as you train to get, to become a nurse, to become independent in your practice. The hidden curriculum, once you're being actually onboarded at the institution that you work at, There are a lot of hidden things, but also overt things that shape the way that you think about problems and about patients and about the care that you provide. And then there's also a diversity tax where people who are of a minority, that might be an ethnic minority or gender minority, that they are disproportionately, quote unquote, taxed by being asked to sit on committees like EDI type committees. And these have less academic currency. They don't pay as well as some other roles people could be doing with their time, like a leadership role. So these are some examples, and I'm sure you can think of many more in your own experience. And the question is, what can we do about this? Can we counter systemic bias? And the first point is to be aware of it. And that's actually gaining some traction these days. The way that we can counter things at a systemic level is really through policy change. There are many policies that are being considered and some that are already being put into place that can re-examine where bias can creep in and what we can do about it. We can also look at equity promoting policies like universal healthcare, drug coverage, EDI-based recruitment strategies. Unfortunately, some of you may have been listening to the news. They've gotten rid of that in the United States now, which is, I think, a step backwards for EDI, for promoting EDI, but that may change over time. But policies have a big influence on this. The other way that we can do it is through education. And this, all of you are here, so I'm really preaching to the choir, but thinking about it, learning about it, learning about what you can do about it is part of creating awareness and also finding ways to find allyship to address some of the microaggressions that happen in the workplace. Another area where bias can creep in is in your own level. So I want you to consider whether you've actually had any of these individual biases before. So if somebody comes in and they're of the same background as you, maybe they grew up in the same neighborhood, maybe they have the same culture as you, maybe they look like you or dress like you, maybe they have the same profession as you, you may feel an affinity towards them. Another one is a halo effect. So if you think that somebody is good inside, if they're good intentioned, you may actually put a bit of a halo around them. And even though objectively what they do is not so good, you may have some positive qualities and attributes that you project onto them because you think that you believe deep down inside that they are good. This is a common thing that parents have around their children. They, their child may have hit somebody, but the parent doesn't think, okay, my child is bad. They might think, okay, my child is being naughty or being bad, but they're actually a good kid on the inside. This is a common example of that. And then confirmation bias. And I think this is one to really examine when we're thinking about both ways. Are we confirming that somebody of a specific group is doing a stereotype that you think is associated with that group? A very common one that comes up is, okay, somebody who's Indigenous, so well, they're slurring their speech, they must be intoxicated, as confirmation for that. But if we talk about Brian Sinclair, who actually was not intoxicated, he had a blocked Foley and was septic. That's a way that you might actually be led astray through confirmation bias. So what's the impact at the patient level of these systemic and individual bias among healthcare providers and the healthcare system? So this is from the Joint Commission, which is a quality improvement and patient safety commission out of the United States. Interestingly, since the new administration came in, this document has unfortunately been removed from the website. And so this is what they say. The difference in treatment and clinical decision-making, though unintentional, could lead to failures in patient-centered care, interpersonal treatment. Does the doctor or nurse care for you? Communication, for example, did the doctor answer my questions or did the nurse answer my questions? As well as trust and contextual knowledge. So the knowledge of your values and beliefs. How a physician communicates, or his or her body language and verbal cues, can be an expression of subconscious bias. So how does this affect the patients that we see in our care? There are labels that can affect different clinical decisions and behaviors that impact that impact the way you manage things, such as the way a patient seeks care. Are they delaying care or avoiding care? Perhaps this is a way to, some healthcare providers might think, oh, well, they didn't come in, like they really didn't care about this condition. I work with a lot of patients who use substances, and they are so scared to come into our emergency department. And this has been studied actually in with local data. They are so scared to come into our emergency department because they're worried about being mislabeled or judged or biased against, that they delay coming in. And so then we see them at the end stage of an illness when they're in extremis. And of course, the providers might think, oh, well, they don't really care. Like they're busy doing drugs. They don't really care about their condition. They haven't come in and it's gotten this bad. The labels that we provide, that we attach to patients may also cloud the way that we think about their treatment plans. We talk about medication compliance. Well, it's actually adherence because the patient has a choice. That we talk about prescription refills. Are they getting their refills? Are they able to get there? There might be socioeconomic barriers to them being able to have gas in the car to get to the pharmacy to fill their medications and then go back to where they live rurally. And there's also a subjective interpretation of healthcare quality that might be misaligned between what a provider thinks is good quality care and what a patient actually values as quality care. These bias can also impact the way that disparities are perpetuated among different populations. So there's good research to support that women who need a TKA, which is a total knee arthroplasty, known as a knee replacement, they're less likely to receive it, even if it's clinically indicated. These biases are among healthcare providers, and they can unconsciously impact care, even if the provider is well-intentioned. More specific to the patients in our emergency department, here's what the evidence shows about implicit bias. Younger patients who had a heart attack, a myocardial infarction, when they were women, they were 7% less likely to seek care for a heart attack. And they were 16% less likely to be told that their symptoms were coming from their heart. Anxiety, stress, other unknown illnesses were alternative diagnoses that they were given compared to their male counterparts. When they looked at resident physicians in the US out of a pediatric emergency department, they had them do the implicit association test that I talked about earlier in the lecture. And their scores post-shift were worse when they were working in an environment where there was ED overcrowding, and when they were working in an environment where they were looking after a lot of patients per shift, so more than 10 patients in a shift, they had worse implicit association tests. And understandably, it's hard to check some of your own biases the more exhausted you are, the more stressed you are, the higher your cognitive load. As well, when they looked at pediatric patients that presented with a fracture, they were 14% less likely to get opiates if they were a visible minority. And when they were given pain medications, 20% of people who were visible minority were less likely to receive adequate pain control compared to their white counterparts. Okay, so we've got literature to support that this is a thing, and it's a thing in many different settings. What can we do to mitigate the impact? There are a few different times where you can try to think about potential high-risk situations so that you can try to control your own biases and that it doesn't impact your patient care. So certain environments with certain populations that visit your nursing stations and hospital, different personal contexts that you might have, and when you're thinking fast. And we're going to talk about all of these. So from an environmental perspective, you want to think about, pardon me, from a personal perspective, you may want to think about times that are when you are at a high risk of bias. So when you are tired, when you're hungry, when you haven't peed in like so many hours and your bladder is bursting, and or if you have other personal stuff on the go. Maybe you get a text about a kid who's sick. Maybe you get a text about a loved one and you're worried about them. Maybe you're having an argument with a colleague or with somebody at home. All of these things distract us and make us more vulnerable to being influenced by our implicit bias. And it makes it harder to check them. Does this mean that you're a bad provider? Absolutely not. It means you are human. But these are some high risk times so that if you think about it, maybe you can check it. Other times are when you're in an environmental context where either you're cognitively totally overloaded or your environment is chaotic. There's interruptions, there's noise, you're trying to make a lot of decisions, or you've been given a whole ton of orders by your physician colleagues, and you're like, okay, I have to do this for a patient in this room, I have to do this for a patient in this room, I have to get this patient home, and then there's pressure to do it all quickly. One of the higher risk areas is actually a fast track environment. And where that patient is brought in from triage, if they're seen in a spot that's usually used for faster turnover patients and more quote unquote minor problems, you may be biased to not think about the potentially more major things that could be going on and potentially miss that. I've also in these slides put a few tips that I've sourced from some colleagues and from myself and from resources in the literature of ways that you can mitigate these. So I'll talk about them as we go through as well. So if you are feeling tired, hungry, need to pee, try to see if you can meet those needs. Have a quick snack, go to the washroom, take a break before you see a high risk case. And we're going to talk about cases where there's a higher risk of having implicit bias affect your care. At times where your brain is totally maxed or the environment is chaotic, see if you can defer interruptions. From a physician perspective, sometimes I'm giving handover, or sometimes I've got multiple patients on the go and a colleague needs to talk to me. I'll see if I can say, okay, can you hang on 1 second? Let me just finish this task. And then I can have this discussion with you so that you can finish your thought and don't get interrupted with your thought process. If there's a way to do when you're doing your nursing handover or team huddles, try to find an environment that's a little bit quieter in order to let everybody's brains be more relaxed to take in the information in a less biased way. And then when you're running your list and your to-do list, think about whether you can go backwards on your list, because maybe you go from rooms 1 to 8. Well, see if you start with room 8 and then go back to room 1. Do things in an opposite way that allows you to think a bit differently and get out of your usual routine. For the fast track area, consider what if this patient was in a resuscitation bay, or what if they were seen in a different setting? What would be done there? Okay. So we talked about some populations that are at a high risk of bias, and none of these, or some of these may not surprise you. People who use substances, when they come in and you think, okay, well, this person is intoxicated again, they very well may be. But think about, is there anything that's not explained by this suspected substance? Could we be missing anything else? For patients who have cognitive impairment, be that dementia or mental health disease, we see this a lot with patients with anxiety or schizophrenia. Their terminology may be different. So in the second case that I brought up with the lady who had a history of schizophrenia, she was talking about, she had a very odd way of telling me about this patient that had come in, that she had been assaulted. And she was talking about sort of magical creatures coming in and having, she was using terminology that would, in other contexts, make me think, okay, well, maybe this person has persecutory delusions, but she actually did have evidence of injury. So the language that they use may be a little bit different, but don't dismiss it. See if you can follow what they're trying to get at and see if it actually could be parallel talk for a problem that they're having. The other thing to think about is repeat vitals. Nurses have a huge impact on repeat vitals because you're largely the ones doing it. And so if you're worried about a patient, repeat the vitals. And if they're abnormal, see if you can address those and explain them before you ignore them. Patients who have a high frequency of emergency department or nursing station visits, often it's ho-hum, same problem. But if there's anything that doesn't fit that pattern, try to figure out what's different about it today and could you be missing anything? This is also similar with patients who have a high rate of unscheduled return visits. So if they've been here 4 times for a problem that isn't going away, it might trigger you to think about, okay, what's changed? What could be different? And also, what haven't we thought of yet? Another high-risk population are patients who have a language or a cultural barrier. They may communicate symptoms differently, and they may not have the right words for it. So they may say sharp pain, but they may mean actually acute onset pain, and the pain may be dull rather than more pokey or focal in nature. This is where also getting an interpreter might be helpful, either a family member if that's what's available, or using professional interpretive services if you have access to those. And then the final thing is to think about blameworthy conditions. Some of these blameworthy conditions might be obesity or type 2 diabetes, and the patient isn't working hard enough to keep their condition under control. Think about how hard it might be in their context and appreciate that even though they're making a reasonable effort, they may still have an out of control condition. The other way, and we're going to talk about thinking too quickly, but the other way to control some of this stuff is consider what if they didn't have that label. So if they weren't somebody who used substances, if they didn't have obesity, if they hadn't been to the emergency department already 5 times this week. Think about if they didn't have that, how would you manage them? Okay. So there's a well-known book, Thinking Fast and Slow. Some of you may have heard of this. And it's really to get at these systems 1 and systems 2 thinking. The systems 1 is the fast thinking. And this is where implicit bias is. It's the subconscious thinking. It's the, as I talked about in the video, when somebody says peanut butter, I'm going to say jelly or jam because we're in Canada. You may actually make those associations without even realizing it. And some of those associations just allow you to survive from day to day. And it might be when you cross the street, you automatically are looking for cars. That lets you survive. It's a survival mechanism. And we can't have a huge, abundant thought process going into every tiny decision that we make because that would be overwhelming and we wouldn't be able to get through our day. However, they are prone to error. And this is where your systemic bias can influence these fast system thinking. So if we are thinking fast and we are relying on what we call heuristics, so heuristics are a way of thinking that allows you to basically attach a set of labels or common presumptions to a condition, whether or not they're correct. So when you're doing that, just be aware that you actually may be doing it incorrectly, and think about the high risk times that we talked about on the previous slide about when personal factors or environmental factors or patient factors may be influencing that, and when you need to start thinking a little bit more slowly. Some of the times when you're pushed into a systems 1 type of thinking is when you're thinking fast, as we talked about. Also at times when the answer is offered. So this might be done at triage when the triage note or the triage nurse gives you handover and says, okay, well, this patient is pretty dramatic. They're like they say they're in 10 out of 10 pain, but they're texting on their phone, looking really comfortable. Or if a colleague is handing over to you, said, oh, this patient is so much, their expectations are unreal. They think that X, Y, Z, but I really think that they are ABC. And they suggest a diagnosis or a plan. And this could be a healthcare provider. This could be a family member suggesting this. And just be sure to, when that answer is offered, think about whether this is actually truly the case and try to verify that on your own. And a final of many ways that you could be pushed into thinking fast is if you're trying to get the patient out or move on with the management plan and there's something that doesn't quite fit. So if you're like, yeah, I'm going to ignore this tachycardia and I'm just going to send them home, or I'm going to, their hemoglobin's a little bit off, but I think they're going to be fine. It could very well be, but just make sure that you use that as a trigger to think through, could this be something else? If I'm sending home a patient with chest pain and ongoing tachycardia, I'm going to think about, could I be missing a PE? Do I need to test for it? What are the return to care plans so that, even if I've decided not to test for it today, that we may catch that and tell them when to come back. And then documenting pertinent negatives is another thing. So convincing yourself that what's absent that may be important in guiding your decision making. Okay. So here are some tips that I've gotten from colleagues, from physicians and nurses, also from myself and from some resources from the literature. And I've tried to distill them down into a few points. So these are all supposed to be things that you can take home and implement on your next shift. So when you're caring for a patient, imagine yourself in their shoes and think about their perspective and what they're feeling. And that can help get around some of those presumptions. I talked earlier about patients who use drugs. They really don't want to come into the emergency department because they feel they are going to get judged or stigmatized or not get the care that they feel like they need. So before going into that encounter, imagine yourself in this person's shoes and see if you can treat them accordingly. And what this does is it helps you think about yourself as an ally in their care, walking alongside them in their journey as opposed to treating them and kind of sending them back on their way. This may make this small but important difference in reducing the biases you may have. There are also some formal cognitive and emotional regulation strategies. There's the pause model that I'll throw up on a slide in a little bit. And then there's also things like debriefing, compartmentalizing, doing box breathing, positive self-talk, visualizing. These are all ways to try to control your own emotions related to something that may have happened prior in the day, may have happened in your personal life before seeing the next patient. Sometimes this is also helpful during a patient encounter. A classic example is patients who have borderline personality disorder. And when you feel yourself starting to get frustrated with them, some of these techniques can also help regulate your own emotions so that you can successfully get through an encounter. Sometimes you feel really off, and it helps to just name that feeling and saying, okay, wow, that patient was like super challenging, or I'm so frustrated with this patient. It can help validate what you're feeling because what you're feeling is actually real. And then once you name that feeling, try to think about the next step, which is, okay, how can I navigate this now? What can I put in place? What are some management strategies I can use to try to navigate these feelings and still provide good patient care? This next point is about appreciating the difference in your bias. I talked about a little bit already. For example, people who use substances not wanting to come and seek care. This is similar to patients who are of any equity deserving group or minority, people living with a disability, people who are BIPOC or LGBTQS2+. They may have a different lived experience than yours. And entering an encounter and realizing, okay, this person has an entirely different world than me and with different challenges that I may not ever understand is a way of setting up your encounter so that you can be curious and try to explore what their experiences are and what their values and perspectives are to let you align some of your management according to their worldview. And then finally, reframing some of these things. One of my colleagues put this very well, and as a reminder that nobody on their 6th birthday thought that they would go on to use substances, to be homeless, to be transgender. It's not something to have a disability. People don't choose this to a large extent. And so trying to think about, okay, this isn't really their choice. There are things in their life that led to this, and they did make a decision around certain things in their life, yes, but they didn't set out that way. And so just acknowledging that might help align your frame of reference with theirs a little bit more and reduce some of that implicit bias. Okay, here are a few different things that you can do as well to reduce some of the negative feelings that can come up with certain patients, especially if you're noticing them. Trying to connect with a patient. And that might be finding a way to connect with the patient in front of you that's challenging. Or it might be an overall effort to, on your shift today, can you find one way to connect in a meaningful way with a patient that might actually just bring your stress levels down, that might make you feel like you've made a difference. And then that can put you in a better frame of mind when you're seeing the rest of the patients that you need to see. Another way is to take the thousand foot view. We know that we undertreat pain in people who are visible minorities. We know that we are more biased against Indigenous populations, thinking that they're more likely to be intoxicated than to have a medical problem going on. Can you, for marginalized groups, you may want to think they've recognized that they've had some bad healthcare experiences and try to see if there's anything you can do today to change the experience for that one patient in front of you. And then appreciating that while this is all lofty and great, it's impossible to do this for every patient. And so if you can solve one problem in a day, or try to solve what you can, then that's already better than what you were doing before and what we as providers were doing before. There's a few ways of wording things that can also reduce bias. I'm just going to leave this up for a couple of moments rather than talk through it because it's pretty wordy. So I'll let you just read this for yourselves. And if you're interested, you're welcome to take a screenshot and reflect on this later. I understand that you've had some workshops on trauma-informed care, which certainly align with some of these things, and just being mindful of the wording that you use. So this is the pause model that was published in 2021, and it's a way to try to check your own bias. So paying attention to what the external trigger might be. So thinking about those high-risk environments or high-risk patients or high-risk personal contexts where you may be more prone to bias. Acknowledging your own assumptions. So what do I think about this? Why am I thinking this about this patient? Is this assumption correct? Trying to understand your perspective. As the S stands for seeking different perspectives, and this is inclusive of the patient's perspective and other healthcare providers, and perhaps your own. And that goes to that tool of, okay, what if they weren't a patient with XYZ? What if I didn't see them in this fast track area? What if these things weren't true? If this was different, would that change anything that I'm doing? So try to change your own perspective and challenge your own perspective. And then finally, examine your options and make a decision. So how could you treat this patient? What's possible? What's not feasible today? But what might you be able to do? Here's another box that as a suggested checklist for making good clinical decisions. I don't really like to use the word good, but I think that's a little bit of a loaded term. But again, something to reflect on. You can take a screenshot of this. You can copy this. You can come back and reflect on these and maybe just pull them out mid-shift and just think about some of the things, some of the patients that you've seen. Is there anything you can change? Okay. So let's go and revisit the cases that we talked about at the start of this discussion. So this 43-year-old gentleman who had alcohol use disorder and was living with his mom, and his mom called an ambulance on him to try to get him admitted to hospital because he wouldn't stop drinking. How might that make you feel as a provider when you see him back in the emergency department? You worked so hard. You came up with a really good plan. You spent that extra time with him. Maybe you think some things about his culture. Maybe there's some judgment placed on his culture. It's frustrating. And maybe you don't like the culture. You don't like those values. They don't align with your own. That's okay. You're allowed to have that opinion, but how can you try to be aware of it and try to not let it influence the way you manage him? How would you manage this patient? Just think about it. What would you do for him? And then I ask you to think about if your management would change if this is what the patient looked like. What would change? Why? This person is maybe not living with his mom. This person looks like he's got a full-time job. He's wearing his safety glasses. Will that change the way you manage this patient? So as a case resolution, this patient ended up being admitted for alcohol withdrawal and to connect him to some outpatient resources. Okay, let's think about this patient. This is the patient who said she was assaulted, has a history of psychosis. There's blood and broken glass all over her apartment. How would you manage her? Is there anything that you could do to verify or disprove the story? She's using weird words. She's talking about how there's demons in her home and they're out to get her. She's talking about how she's got butterflies in her arm and her arm is bleeding. So for case resolution, this patient with the demons in her home, I think, was talking about an intruder. And with the butterflies in her arm, I think she was talking about paresthesias. So I examined this patient myself and I got her story, and it was a little bit bizarre. But then I looked at her injuries and I asked her what hand she wrote with. So she was right-handed. And all of her injuries were on the ulnar side of her right hand, where she would potentially be defending herself against somebody. So when they're on the dominant side, they're less likely to be self-inflicted. So the police actually did go back and review footage, and they found that somebody had broken into her apartment and had broken in through the balcony. And then they eventually got the suspect. So she was using different language. She had a history of psychosis. It was really easy to potentially turf her and say, okay, you need your medications adjusted. Maybe you need admission because you're not coping well at home. You're not safe to yourself. But actually, she was telling the truth, just in a very strange way. And that was just her way of trying to communicate. Finally, this patient. There's a little kid sitting right outside his room, and he has to go past this room to get a visual acuity test. Do you want to scare the kid? What would you do? Would you just bring him? So eventually, we spoke with the nurses because they flagged this for my attention, and we did talk about it. And we did notify the family that we were going to bring a patient past them, and we did let the mom know that somebody was going to be coming by who had been assaulted. So she tried to distract her child, and then we were able to get the visual acuity and bring him back. I don't know if that was right. Maybe we should have just brought him. There's no good answer. Just think about what you would do. So, to wrap up here, the first step to reducing implicit bias is to realize that everybody has it, and it doesn't mean that you're a bad person. It just means that you've grown up in a world like everybody, that you are learning things and you make these associations that let you function in your day-to-day, but that it also may impact some of the care you provide. So if you can identify times that you can that you're at a higher risk of bias, then you can mitigate it. And we talked about some strategies. So think about what types of strategies you may use to take to reduce the bias in your own practice. Huge thanks to the team that I work with here in Kingston and to your group. And I just wanted to put up a QR code. If you don't mind filling it out, there's also a link there. I'm not sure if it'll work if you press on it. But if you use the QR code, if you're able to tell me one thing you liked about this presentation, two things that you may change in your practice, and then, two things that you would change about this lecture, and three things that you would implement tomorrow on your next shift. And with that, I am very happy to take any questions. I will just leave this slide up here.
So thank you. I know for those of you who came this morning, it's a little bit different topic than we normally cover in our morning education sessions. Any comments, feedback right now? Questions? Where you'd like to see us go next with this?
In reflecting, has anybody thought about a case where they thought, oh, maybe I did have some implicit bias that influenced the way that I treated this patient? Has anybody seen it happen in others, in their colleagues?
I maybe just want to comment on your second case, and
Mhm.
interesting how the comments of others can really guide us, right? Like the comments of the police in that case, and that it sort of starts to tunnel our vision, right, about a client.
Yeah, absolutely. We're all human. This is not a lecture about shame or blame. It's just some food for thought to see if there's any way that you can change your own thought processes.
All right, hearing no comments. Thank you very much for the presentation. Thank you this morning for everyone who gave us an hour of their time. And we will see you all next week. Have a great day.